Okay, another one of the protocols that had some pretty significant changes to it is the non-traumatic abdominal pain protocol. This is the adult version that we're going to go over here first. Um, so previously, we weren't allowed to give any pain medicine to abdominal pains. The reason for that was there was this thought that if you treated the pain, you couldn't diagnose the abdominal pain because the physicians at the hospital wouldn't know where to look and they wouldn't know how to assess them. While that was true back in the day before all the imaging options the hospital has now, like CT and MRI, uh, it's kind of changed now because they have CT. Most abdominal pains, if there is a cause to it, are diagnosed with a CT scan or some other type of scan. So the protocol starts. This is for patients with abdominal pain without a history of trauma. Your assessment should include specific questions pertaining to the GI and GU systems. So ask the patient to point to the area of pain, and whatever area they point to, that's the area you palpate last. So gently palpate their abdomen, assess for tenderness, rebound tenderness, distension, rigidity, guarding, and a pulsatile mass. And also palpate their flank pain or their flanks for CVA tenderness to try and rule out anything that could be like kidney related. Ask about their abdominal history, including their pain. So OPQRST, if they say they've been nauseous or vomiting, what color is it? Is it bloody? Does it look like coffee grounds? How often? That kind of thing. Ask about their last bowel movement, if it was diarrhea, if it was bloody, if it was tarry, how frequent it's been, history of urine output. Is their urination painful? Is it dark? Is it bloody? Does it have an odor to it? Those kinds of things. Ask them if they have a history of abdominal surgeries, because that kind of helps rule some things out. And if they have an acute onset of back pain, that could be referred pain, so ask about that. And make sure you just get like a good sample history, including their last oral intake. If you have a female patient, make sure you include some questions about their OBGYN history. So, especially if they're childbearing age, most abdominal pains in females, according to the protocol, should be considered an ectopic pregnancy until proven otherwise. So, some examples of things that can cause abdominal pain are appendicitis, cholecystitis, duodenal ulcer, perforation, diverticulitis, AAA, pelvic inflammatory disease, and pancreatitis. So for EMTs, you guys doing routine patient care, make sure your patient is NPO or nothing by mouth, no food, no water, nothing to drink on the way to the hospital, or before you leave the scene for that matter. Administer oxygen to maintain SpO2 above 94. Transport in a position of comfort. And then advanced CMTs, you guys want to obtain an IV access, bolus any fluids to maintain a MAP greater than 65. I think it's important to note on this protocol, it says a MAP greater than 65 as opposed to a systolic above 90. Probably the reason for that is just in case your patient is having a AAA, you're not, making their blood pressure so high. You just want it high enough to perfuse their organs, right? And we've found that a MAP at 65 is where that's at. If they're nauseous, treat them per the nausea protocol we just went over. If they say they're in severe pain, so that's like a 6 or greater on a scale of 1 to 10. Advanced EMTs and paramedics, you guys can now administer fentanyl 25 to 50 mics IV, IO, or intranasally every 5 minutes up to 100 micrograms total. Or you can do morphine 4 to 8 milligrams IV, IO every 10 minutes up to 10 milligrams total. So we got a couple different options for pain management for abdominal pain. I think that if a patient says they're in that much pain, then you should treat it because it's not our role to tell the patient how much pain they're in. The hospital is pretty good about doing this, but I think in EMS we kind of hold ourselves back in that area. So I just think that if if the patient says they're in that much pain, then they are. So make sure you treat it. You want to make their experience as comfortable as possible. Um, with that being said, also if you're giving a patient narcotics or opiates, um, I would also put them on Entitle. That way you can monitor the respiratory rate, and it kind of gives you like a live respiratory rate as opposed to you have to continuously watch the chest. Paramedics, make sure you place the patient on the monitor. If signs of decreased perfusion or shock develop, initiate fluid resuscitation, and be aware that ischemic cardiac pain can present as abdominal pain.